and have so many amazing speakers. So I'm going to kick it over to our first speaker today. She is from the Office of the Attorney General, and she is the Health Bureau Chief, an absolute expert on everything abortion policy. Please give a hand to Darsana Srinivasan.
Thank you, Sophie, and thank you to all of the other speakers today. I'm really looking forward to learning a lot. So as we know, Dobbs came out about 3 months ago now, and the leaked opinion was slightly earlier. And if you read the opinion, they talk about how Roe v. Wade created rancorous national controversy. And I would argue that their decision has done exactly the same. So we're not in a place of settled law. We have a lot of confusion. We're not exactly sure how any of these new laws that I'm going to discuss will be applied, what their actual effect will be versus, what their intentions are. But we can tell you that on the ground, everything we expected to happen is happening. Physicians, providers are worried. They're facing a much greater risk, even when they lawfully perform abortions in free choice states like New York. They are worried about losing their licenses. They're worried about their safety. And from the safety front, there have been increasing protesting activity. I would describe it as attacks on clinics and facilities everywhere from Buffalo to Long Island to, Midtown Manhattan. It's really just widespread and ever increasing. So against that background, our legislature acted, and I believe partially they acted very quickly, not just because of Dobbs, but that a lot of folks were thinking about this, including folks here at my office in the Healthcare Bureau, at the Attorney General's office, when SB 8 came out late last year, which was thinking about how other states would try to control actions and legally and lawfully provided care in other states. So I just want to talk about the laws that have been passed, and everything I'm going to mention right now was not only passed by the legislature, but was signed by Governor Hochul, and all of these laws are presently in effect. So there were sort of discrete buckets of policy initiatives, and the first were provider protections to really help healthcare providers and offer them procedural protections from what we saw as being the extraterritorial reach of other states' laws. So, if you're thinking about SB 8 and its bounty hunting statute, the fact that, a physician here in New York who is lawfully and legally provided an abortion to a patient in New York could get sued in Texas. And so to protect these physicians, they passed some very specific provider-related prohibitions, including one regarding licensure and misconduct. So it prohibits the bringing of professional misconduct charges or licensure restrictions against New York licensed healthcare professionals who provided abortions to individuals who reside in, say, hostile states where those services are illegal, as long as those services were lawfully performed here in New York. Obviously, if there were any other issues or tort-related issues, you could still bring those, misconduct charges. And again, that is in effect now. In addition, we offered medical malpractice insurance, and we've been seeing some complaints that healthcare providers are facing higher costs, additional fees for providing these services. And so it's intended to protect against rate increases, the loss of insurance coverage, a variety of unfavorable terms. And again, it only covers care that is legally and lawfully provided here in New York State. So, a physician who wants to do work of the angels and travel to another hostile state is not protected by either of these provisions. Obviously, and just returning to licensure, if a physician is also licensed in a hostile state where they, say, perform an abortion here legally in New York on a resident of that state, they could lose their license in that other state, and there's nothing, New York can do to protect them. There's also a whole raft of laws, I should say, to try to protect providers from criminal investigation. And again, these laws were intended to do the best that they could, but if you're familiar with the way, criminal investigations work, it's not always clear that, a warrant or a subpoena is related to the performance of an abortion. You can imagine states knowing this, the hostile states will come up with ways to phrase it under other types of laws. You know, it's going to be murder or, you know, conspiracy or something else that it's not clear to, you know, a police officer looking at a warrant that this is what this is about. So some of the protection that we've attempted to extend to providers is extradition protection, so they cannot be extradited to a hostile state from New York. Obviously, this wouldn't protect a provider if they were traveling in another hostile state that, you know, for some reason would be willing to extradite them to that state. That could happen. So again, providers have to make lots of choices about how they live their lives, you know, where they own property, how they travel, where their kids go to school. This is all consuming. Secondly, we have prohibitions on police officers arresting someone for performing, receiving, or assisting in a lawfully performed abortion in New York. Again, you can imagine, even if that was the case, the warrant, the information may not be clear on the face of the document that a police officer would know that's why this person's name is here. You know, they might think it might be for murder or some other tort or some sort of charge. And so they might arrest them, and this has to get cleared up later. So of course you can imagine providers might be subject to quite a bit of harassment before these things are sorted. There's also prohibitions on law enforcement from cooperating with investigations by hostile states into lawfully performed New York abortions. Again, they still have to comply with lawfully ordered subpoenas. So again, there's limitations on how far that protection can actually extend. Obviously, it doesn't cover, you know, other forms of information gathering by those hostile states. They can, you know, send subpoenas to Google or, you know, other social media platforms, or conduct other sort of forensic work to determine whether someone has received an abortion in New York that does not involve, you know, contacting the local police department. And then lastly, New York courts are prohibited from issuing subpoenas in conjunction with another state's proceeding. However, again, if a subpoena or warrant is, you know, duly ordered by another state, New York law enforcement has to follow it. So again, these protections exist. They are in effect, but they are limited. And as we know, nothing has been fully tested yet. There are also beyond protections for just healthcare providers. There are protections for those who are seeking the abortion, obtaining the abortion, and then those who are assisting, or as they would say, aiding and abetting abortion care. So one of the most interesting is the monetary recovery for civil suits. This was mentioned in the press as the Fire Hate Act. So this would provide any of these categories of individuals who are sued under another state's law in a hostile state to recover for their monetary losses, the cost of defending that lawsuit in that state, and then any adverse judgment that might be entered against their state, against them here in New York. So they have to bring the lawsuit here. There are some additional protections that we also have. This one just went into effect on September 12th. It's an expanded address confidentiality. We have a Department of State program that has been limited to survivors of domestic violence and victims of human trafficking, and has now been expanded to include healthcare providers, patients, volunteers, anyone who, you know, assists or otherwise, you know, provides us, you know, or is even a family member to join an address confidentiality program where the Department of State will issue a substitute address. So you don't have to reveal this information. As you can imagine, again, this is another way of providing some protections for patients and, again, healthcare providers from the host of protesters and other anti-choice advocates out there. So these are our laws that we have in place right now. Again, none of them have been tested. All of them have limitations. Any provider or patient should obviously seek legal counsel if they have serious concerns. Our office has a hotline, which you may be familiar with, that providers, patients, individuals can call. Here in New York, if you're from outside of New York, we'll try to find you a referral to a provider who can provide you with that assistance. But we're trying to make sure that, you know, everyone is getting the care that they can receive, that people are working within the level of risk that they feel comfortable doing so. It's just that the entire landscape is very uncertain at this point. So we have to see what happens.
Thank you, Darcina. Can I ask one question? And if anyone has questions, please feel free to put them in the chat as all of our speakers present. My question is, how do the laws that you're talking about that are targeted to support providers, how do those impact abortion funds and those of us who are working to aid and abet?
So there's a few provisions that I mentioned that protect people, like the shielding from criminal investigation is supposed to protect people from who also, assisted in or again, they say aiding and abetting in an abortion. So that could help the abortion funds. I will say there's been, again, every abortion fund has a different level of comfort with the risk level that they're facing. So you probably heard there's a public policy from the National Abortion Federation where they're requiring anyone who takes abortion funds to make clear that if it's a surgical abortion, it's occurring in a free choice state. If it's a medication abortion, both doses are occurring in a free choice state. So they're trying to shield themselves from this liability. Again, nothing has been tested, but these laws do exist to protect those, someone who drives someone across the state or someone who provides money. But again, we don't know what the taste is or the capacity is for these DAs in anti-choice state to pursue these actions. I will actually note that there is all of these protections, again, are for lawfully performed abortions in New York, which would mean, having a surgical abortion here in New York State or taking 2 doses of medication abortion in New York State, because those are lawfully performed or in a legal state. There is a new bill out, which is Assembly Bill 1066-3, which would expand protections under a variety of these procedural protections to providers who offer medication abortion over telehealth. As long as they are lawfully in New York, it does not matter where the patient may reside, such that abortion will be determined to be lawful under New York. Again, we don't know what the legal ramifications of that will be because, again, telehealth is generally defined by the laws of the state that the patient resides in. But we have this draft bill right now that's been recently proposed that would change the definition of what, telehealth medication abortion would look like. So.
Amazing. Thank you so much, Darsana. That was so informative and interesting, as always. Thank you. So I will say that I used to work for Attorney General Tish James, and there is absolutely no sunlight between the AG's office and those of us who are advocating and performing abortion care for folks throughout the country. And Darsana is really one of the main reasons why that's the case. So thank you so much for being here. I wanted to say one thing based on Darsana's presentation is that something that you may not know, that every person, every policymaker should know, which is that a medication abortion is 2 different pills that have to be taken 24 to 48 hours apart. So you take the first pill you swallow, it's called mifepristone, and you then 24 to 48 hours later, you take 4 pills of the second type of pill called misoprostol, and you dissolve those in your cheeks 24 to 48 hours later. The first pill stops the pregnancy, and the second expels the tissue from your body. So, and then following the second pill, you have cramping and bleeding. So everyone should know that. And thank you for mentioning it, because that's a really important thing for every policymaker to know. Okay, so our second speaker today is going to talk to us about the trickle-down effects of the tragic overturning of Roe v. Wade. We all know that when abortion is made illegal, women's health suffers in all categories. So to talk to us all about birth control, please welcome the Director of Advocacy from the New York Birth Control Access Project, Rochelle Rodney.
Hi, everyone. So first I want to thank Sophie for inviting me, and thank you everyone for being here. So I'm Rochelle Rodney. I'm the Director of Advocacy at the New York Birth Control Access Project. And the importance of reproductive health care at this very moment cannot be overstated. I've been in a lot of different rooms where I've been talking about reproductive health lately with a lot of young people, and I'm very excited to see how excited young people are to talk about reproductive health now, especially after the Roe v. Wade decision. And at the New York Birth Control Access Project, we're focused on increasing access to birth control with the understanding that we need birth control and abortion also to be easily accessible. And there are several policy developments regarding birth control right now that I want to speak about, and I'm happy to talk about today. And the first one that I'll be going over with you guys is the Comprehensive Contraception Coverage Act, or the CCCA. It is a law that was passed in 2019, and for the most part, it codified into state law the pieces of Obamacare that improved access to reproductive care. So this includes like birth control or free birth control and yearly exams. And under the Comprehensive Contraception Coverage Act, it took access a little bit further, 2 steps. So now insurance companies are fully covering an extended supply of birth control. And what this means is that a patient is now able to walk into their pharmacy with a prescription for a 12-month supply of birth control with 0 refills, and they'll be able to get their full year supply of self-administered birth control all at one time. And we've done some work with the Attorney General, Letitia James, on this, where our organization did, I don't know if I should use this term, but some secret shopper kind of work, where we realized that insurance companies weren't cooperating with the CCCA. And we decided to figure out which insurance companies knew about the CCCA, who were complying with the law. And every insurance company that we called about 5 of them, did not know about the CCCA even existing. So what that proved to our organization was that there was an implementation issue of the law. And based on the conversation that our organization had with Attorney General Tish James, she put out a memo for all of the insurance companies to comply with that specific law. So the first step that it did was to have that extended supply of birth control. And the second thing that it did was also ensure that emergency contraception is covered by Medicaid as well. So now some people can go to their pharmacies and put down their insurance cards, and they will be able to access emergency contraception through their insurance as well. And not a lot of people know about that either. So what we are working towards is finding out what is the best way to implement this law and make sure that all New Yorkers know that they have a right to access not only the 12 months of birth control, but also emergency contraception through their insurance as well. So that is one policy update. However, other exciting news, I know that the FDA is currently getting closer to approving over-the-counter contraception, or an over-the-counter form of birth control, to be specific. So basically what that means, and sorry if you already know that already, is that you will be able to go into your pharmacy and pick up birth control on the shelf. So like next to your Advil, Tylenol, and other products in the store. And now, upon the approval of OTC birth control, we certainly want to ensure that the CCCA or something like it will also cover over-the-counter birth control as well. So not just birth control that is prescribed. And finally, I think that this is the policy update that I'm the most excited about, and that is pharmacists prescribing birth control, or pharmacists dispensing birth control through a non-patient specific standing order. And over 20 other states are already doing this. New York State is not one of those states. And we just want New York State to catch up and be one of the states that are taking advantage of pharmacists having the ability to provide birth control or to dispense birth control through a non-patient specific standing order. And what that would look like is a patient, say for instance, myself, go into the pharmacy, I would be able to walk in and get consulted on all of the different forms of birth control. And if I decide to use a self-administered form of birth control, they would be able to put my name on a non-patient specific standing order. And then I can then walk out of the pharmacy with my birth control that same day without having to visit a provider. And now, since we have the Comprehensive Contraception Coverage Act, if that's accompanied by the pharmacist prescribed bill in New York State, Now I would be able to not only walk in, get a consultation, and get my birth control, but I will be able to get a full year of my birth control and then go back for like checkups to my doctor whenever I feel necessary. So those are the three policies that we're mainly focused on at NYBCAP. And as the legislative session opens up next year, I'm really excited to see which laws do get passed. And I'm hoping that we can come up with like the perfect implementation plan for the Comprehensive Contraception Coverage Act. So does anyone have any questions for me?
I'll ask a question. My question is, I know that a lot of people are concerned about, is it safe to have the pill or another self-administered birth control prescribed by a pharmacist and not a doctor? So that's my question. Is it safe?
So that is a question that we get a lot, awfully a lot. So not only is this promising in other states, but also ACOG, the American College of OBGYN, put out a memo saying that we just kind of link a provider's visit to getting our birth control, because that's what we're used to. That's what we were taught. And they said that it's safe, they deemed it safe, and we also have a lot of support on the bill. And pharmacists, another thing about it is that pharmacists are medication experts. Like they know what they're doing. They have a lot of experience with dealing with medicines and things like that. So we believe that pharmacists are capable of doing so. And another thing that they are looking at when talking about that bill is if it is expanding the pharmacist scope of practice, and if we need to add medical training in there as well. And I see that there are 3 other questions.
Dr. Pena, would you like to ask your question?
Sure. So it's a beautiful plan because it gives accessibility, but I want you to remember that pharmacists are already overwhelmed. So this plan looks beautiful in the writing, but then it takes away the power of the primary care doctor, because you've been mentioning GYN. GYN are essential to actually women's health, and we know that. But in my practice, for example, where I've been in Washington Heights since 2009, since I got out of Newark, the first person that they come to talk about what they are going to use to prevent a pregnancy, and then what they're going to do if they get pregnant, if they don't want to have a baby, is not to the pharmacist. They come to the primary care doctor. So I don't think the primary care doctor should be negated from the equation, because then here comes other problems. Also, remember, oral contraceptives or any type of contraception has side effects. So you need to discuss that with the patient lengthily. And you know that the way that the healthcare system is right now, it doesn't give much time for the patient to actually have a conversation with a doctor. Imagine having this conversation in a pharmacy. So just keep that in mind, please, because in reality, we want things that sometimes will not be the way that we want them down the road. So just an observation.
Thank you for your observation. And I 100% agree that OBGYNs and the primary care providers are important and that people should go see them. We just want to open up another gateway to access. So they will have the option of still going to their OBGYN, still going to their primary care doctors. But for the people that don't have the time to even schedule a provider visit and then schedule another visit to go to the pharmacy, and they are on their birth control, they know what they want, they can also have that option to go directly to the pharmacy, especially for people who have been on their birth control for years and they know the birth control that works for them. Is just another access point for them as well. But I do agree that providers and OBGYNs are an important part of our healthcare system, and people should continue to go see them, and people will.
Yeah, thank you.
Thanks. We have time. I guess we'll do one more question from Beth. Darcy, would you mind chatting your question? Thank you.
Hi, can you hear me?
Yeah.
Great. Hi, Sophie. Great to see you. So one quick question, I might have missed this. You discussed that the FDA is getting closer to approving the over-the-counter contraception as one exciting development. And it seems like under that piece of information. You can just go in and get birth control off the shelf at the drugstore. But then we have this other piece through the Comprehensive Act you've been discussing, possibly where pharmacists are dispensing birth control. Are those two things kind of going to meld together, or is it just going to be like two separate avenues? Can you explain that a little bit more, like what the expectation of how that implementation will work?
Okay, so we're not really trying to mend them together or like mesh them together. They both will stand alone as their own thing. However, both of them like inform each other. So the you have an access at the pharmacy to like go in and get your birth control from you getting consulted by your pharmacist and you being able to pick up your birth control on the shelf. You still have two different options. So they're not meant to like work together, or like both laws aren't meant to like mesh together as one, but one of them will
two separate options, basically. Yeah. Okay,
yeah.
That's what I was trying to understand. Thank you so much for that clarification.
No problem.
Thank you so much. Thank you so much, Rochelle. Thank you all for your questions. We are going to now move. We just heard a little bit from Dr. Pena, but we are going to hear more from her now. As you all know, we have just maybe exited the COVID-19 pandemic potentially. And also there are threats rising from a new disease, monkeypox, and a very old one, polio. And I know that there is a lot to discuss in the pandemic preparedness world, as well as vaccine distribution and all of the ways that we saw and are still seeing our policymakers affecting our personal health as it leads to these sorts of things. So without further ado, Dr. Pena, please take it away.
Hello, everybody. So I'm Dr. Yomaris Pena, and I work for Somos Community Care. I'm the Chief Medical Officer there, but I am also an internal medicine provider at my own practice, which is White Pinion Modern Medicine. I've been in Washington Heights, serving the Bronx and Upper Manhattan for more than 13 years now. And like I said before, I used to work in Newark. That's where I did my residency. So I'm very familiar with community health within the perspective of starting from primary care, from the single issues that affect our communities all the way to big masses. So as being the Chief Medical Officer, now we're going to switch the perspective on a public health type of awareness. What did Somos do? What are we doing? What have we done? And what have we learned? I think that we have to remember a saying that Michael Levitt said, that it's basically whatever we think before a pandemic, it's always alarming, and whatever we think after, it's never enough. And that's where we are right now. We were ready. We were capable of distribute vaccinations and create plans as they went through these 2 years that we all knew. But not only vaccination, we had to do and dealt with something that we didn't know, which was establishing policies and protocols to a virus that no one knew. And how did we do that? I think it was as I call it, the work of all these entities coming together. DOH department, New York State, the city of New York, and then what is Somos? Somos is basically an umbrella of 2,500 physicians approximately, or community providers, because there's also nurse practitioners, all type of doctors within our umbrella that take care of the patients. And because we do value-based care, we were able to actually do also public health when the time was needed. Where are we? So the COVID vaccinations, as we know them, they continue to evolve because the virus continues to change. And therefore, we need to catch up with science. That's what we're doing. Currently, just as an update of the vaccination status and the way that we're distributing the vaccines, we have what we call throughout the summers, different community health fairs that were done throughout the city of New York, in all the boroughs that we were called upon. And we will have these teams of doctors and nurses that will go in and vaccinate as many New Yorkers as we can. As you guys know, we had to fight the misinformation in the Latino community specifically, and the African American community as well, which were hesitant to obtain this vaccination. So we established a plan of education beforehand where marketing was very was needed in the language that the patients will speak. Somos is a sensitive and culturally competent company where, for example, in my case, I have a Caribbean background. I'm Dominican because my parents are Dominican. I'm American as well. But I speak in Spanish to patients that probably won't feel comfortable speaking in English, right? Or they probably don't manage the language that well. So one of the things that we see on these drives that we do is that communities that don't have any type of insurance, for example, illegal immigrants. I'll give you the latest example. We were doing a fair for Univision the other day in conjunction with the Human Health Services, and we vaccinated about 100 patients that were undocumented, and they were afraid to go to any of the places that we have access for other New Yorkers. So these initiatives seem like small numbers, but if we remember, the more we do them, the more often we are out there, the more we're going to help the population. So those are one of the things that we're doing now. And now in terms of COVID, we also started the promotion of the new boosters. The new boosters, just as a reminder for everyone here, are basically made of half of the Omicron dose and half of the regular Delta virus. And why is this important? There are studies that shown that despite the fact that we were fully vaccinated, meaning one complete set, which means 2 vaccines of Pfizer or Moderna, or in Johnson & Johnson, whoever got it, 2 Johnson & Johnson, even if we were fully vaccinated, we were going to be exposed to Omicron and we were going to get infected. And this is because, unfortunately, Omicron is very smart. And as we know, it was an alteration of the previous virus. So now these new boosters will cover that. And we are expecting that with those new boosters, we're also increasing the awareness for other vaccines. And what vaccines are we talking about? We started recently on Monday, we vaccinated the Secretary of Health, as well as the commissioner of the city of New York. And that initiative was mainly to promote that once you go get your flu shot, anywhere you go, either if it's at your doctor's office or if it's at the pharmacy, you also get your new COVID booster. So that way, our offices in primary care and the hospitals don't get overwhelmed in the new season that is upcoming, which is the flu season. And as we know, other viruses with it. So in terms of COVID, we already have that plan. And talking about and moving forward in terms of monkeypox, there's still work to be done there. The city and the health department have done a great job. But I think that what we need to learn from this again is that if we move vaccinations fast, because primary care, think about it. Okay, so now we're going to talk about the stigma in the Latino population, in the underserved community. So I could speak from my background. I am a very open physician. I speak to everyone about any themes, anyone comes to me. But unfortunately, the Latino community still has stigma on the LGBTQ community, right? So if you start opening centers that are based and you start educating in big masses that these are the higher risk population, it's going to be very detrimental for the psychological health of the patient to go into one of these places if they have not disclosed their sexuality. And that happens in a lot of Latino communities. So one way to approach this, because I always say I'm never blaming anybody, because this is not the game that we should be playing. This is not a game. People's are not tools to be used, and the health specifically. We need to always find if there's a gap, how can we fix it? How can we bridge it? So I think that a way that we could always bridge that is through the primary care providers, the ones that take care of the patients, the ones that talk to the patient, the ones that know the secrets of the patients. Because if you go into your private practice and you get the monkey shot, the monkeypox shot, no one will know why you're there, right? So it's kind of the confidentiality and the HIPAA We always have to think about that. Patient comes first. We don't have access to it in our clinics right now, but we are referring patients to all the centers that are available for them. And accessibility originally was a problem, but now it's getting better. In terms of the polio, so polio is interesting because polio has been in the news and it's been a big problem, kind of bringing awareness to all the physicians as well, where we had to re-educate not only the population, but also the primary care doctors, the physicians in general, that are already doing this type of work. So as we remember, polio is part of the vaccination plan that we have for our children. So the pediatricians have been doing the polio vaccine all throughout. So this is not something new, right? So where did we have to emphasize and where are we emphasizing now? We're remembering the primary care doctors specifically that treat adults. What are the guidelines? Do we have to review with our patients on a one-to-one? What is their vaccination status? Have they been up to date with it? Because some patients that are coming from high-risk areas, for example, Afghanistan, Pakistan, which are the highest risk countries where polio has not been eliminated, those need to be made clear and updated in their vaccination. So it's kind of re-educating our providers and making sure that they follow through. But the polio is being given in the pediatrician's offices and all the adult doctors that do vaccinations, which are internal medicine or family medicine. I think that's kind of a big global overview of a lot of topics that we could talk about. But I think that I'm here and open to talk to you and answer any questions that you might have.
Thank you so much, Doctor. I'll just ask a first question. President Biden said the other day that the COVID-19 pandemic was over. Do you agree with that? And what does it mean?
So basically, he wasn't wrong because we have the definition of pandemic is that COVID is in every single country and is affecting big masses. What he was trying to convey is that we are now under trying to get into the phase where immunity is herd immunity because we have vaccinated most of the population. We still have some people that are hesitant, and the diseases that we are seeing now are not as the initial part of the pandemic, right? When we first started, when we didn't have the vaccination, when we had mortality rate going higher. As I spoke at the beginning of me talking right now, I want you to remember that mortality was high at the beginning, and the cases of patients actually developing long COVID were extremely high as well. But the fact that you were vaccinated with the primary series was decreasing and has decreased mortality in big waves. I think that also we have to remember that despite the fact that we have controlled the numbers in terms of mortality and illness, we need to continue reiterating in the population that it is important to continue having public health. So wash your hands. If you're sick, wear a mask. We shouldn't create the mask as a symbol of the dark days that we went through. We should actually promote the mask as a way of being conscious about the others and keeping the others healthy. If you are thinking that you might have a cough and you don't know if it's allergies, if you don't know that if it could be the flu, I think this pandemic should have taught humanity that we need to take care of each other, not only at the moment that you're sick, but whenever you're thinking that you might be sick as well. So that's kind of prevention. So I'm not a politician in that sense, but as a healthcare worker, I do agree that we always have to keep our guards up, the most that we can, and we have to respect others. So yeah, basically that's my answer to you.
Thank you. Beth, do you have a question?
Hi, very super quick question, which is kind of like technical, but in terms of polio, I've done a bit of reading about it, about kind of some of the higher risk countries bringing it here. So from a physician perspective, let's say we just don't know, you don't know your patient's vaccination history, perhaps they don't know. Is the policy that you just get vaccinated for polio then if you don't know if you have in the past? Like, how are physicians supposed to handle that issue?
So first, you have to actually ask for the vaccination record of the patient, which we all do on all new patients that come into the practices. If you don't have it or you don't have it handy, you have to ask which country the patient came from, if it's a new patient in your practice, or the vaccination beliefs that the patient also has, because we know that some people don't vaccinate because of religious background. And then based on that, if you're a high risk patient, you could always get a polio booster when in doubt, and that's available in all the practices.
Thank you so much.
You're welcome.
Thank you. Any other questions? I'd never heard of a polio booster.
Yeah, it is. It's given to the people that are at risk and to patients that don't know, just like she said, like, I don't know if I got it, but no, mostly everyone got it when they were a child. That's why we eradicated it, thank God. Because I've seen cases of polio outside of the United States. They're very sad.
Absolutely. Do we have any other questions? All right. Thank you so much, Dr. Pena.
I'm here for you whenever you need me, and thank you for the invitation.
Thank you. Thank you so much. All right, everyone. So we have one last topic to cover today. It's a really important one, and one that is just not talked about enough, and sometimes at all. We wanted to do a presentation as part of this training on policy that's on the table for compassionate end-of-life care. I will tell you, my best friend in the world is a death counselor at the Children's Hospital at Montefiore. So it's an issue really close to my heart. She tells me all the time about how much her patients suffer needlessly. So I really wanted to make sure that this policy that nobody wants to talk about, nobody wants to support publicly, is getting some coverage and some sunlight. So please, Corinne from Compassion and Choices, take it away.
Thank you so much, Sophie. The organization that I represent, Compassion and Choices, is the nation's oldest, largest, and most active nonprofit organization committed to improving care, expanding options, and empowering everyone to chart their own end-of-life journey. We envision a society that affirms life and accepts the inevitability of death, embraces expanded options for compassionate dying, and empowers everyone to choose end-of-life care that reflects their values, priorities, and beliefs. It's clear that bodily autonomy is under attack, and the Dobbs decision is just the beginning. It's hard to imagine a more intimate and important moment in a person's life when bodily autonomy matters than at the end of life. And I want to thank Eleanor's Legacy for providing the opportunity to talk about a bill that's been pending in the legislature now for more than 7 years. Medical aid in dying is a trusted and time-tested medical practice that allows a terminally ill, mentally capable adult with a prognosis of 6 months or less to live to request from their doctor a prescription for medication that they can decide to self-ingest to peacefully die in their sleep. Medical aid in dying has become part of a comprehensive set of end-of-life care alongside hospice and palliative care in states that have already authorized it. 1 in 5 adults now lives in a state that allows access to medical aid in dying, and an increasing number of New Yorkers are watching as loved ones living in other states experience the peace offered by this compassionate option. Oregon was the first state to authorize medical aid in dying via ballot initiative in 1994. And when a state passes a law like this, you'd expect that there would be tweaks or changes or amendments to these laws. But what we've seen is that Oregon has now served as a model for every other state that has authorized medical aid in dying, because the original framework of eligibility requirements and safeguards worked and has worked for nearly a quarter of a century to ensure that none of the harms predicted by opponents in the early 1990s have ever come to pass. Today, 10 states plus Washington, D.C. now authorize this option, and Oregon's law has served as a model for each one. I mentioned that Oregon has never had to fix or tweak its law because of problems arising from the practice, but I do have a caveat to that statement. While there have been no cases of abuse or misconduct under these laws, what we have seen is that the strict safeguards put in place in 1994 have prevented many terminally ill people who would otherwise qualify from accessing the option. That's why this year, California lawmakers overwhelmingly reaffirmed their support for that state's end-of-life option law, but they eliminated needless, time-consuming requirements in the law after evidence confirmed that patients were dying during the state's lengthy and unnecessary 15-day waiting period. New York's medical aid in dying law was first introduced in 2016. There were several bills before that, notably sponsored by both Republicans and Democrats. But in 2016, we all got together with the bill sponsors, looked at what's worked and what's not worked in other states, conformed the language to other laws in New York, like the Family Healthcare Decisions Act, and addressed concerns raised by lawmakers. And today, I believe that our bill is the strongest in the nation. It still follows Oregon's basic model. Only terminally ill, mentally capable adults can access it. 2 doctors have to confirm that the requesting adult has a terminal illness, defined by the bill as being an illness that is both incurable and irreversible. And from the initial request to the self-ingestion of the medication, the dying person alone is in charge, not a family member, not a healthcare proxy, and not a doctor. Our safeguards are strong and will, like they have for a quarter of a century in other states, protect against any feared misuse. They include the following. 2 physicians have to confirm that the person is terminally ill with a prognosis of 6 months or less to live, is making an informed healthcare decision, and is not being coerced. The terminally ill person can withdraw their request for aid in dying medication, not take the medication once they have it, or otherwise change their mind at any time. The attending physician has to inform the patient of all of their end-of-life care options, including palliative care and hospice. There's a mandatory mental health evaluation if either physician has any concern at all about the person's mental capacity. No prescription can be written unless and until that mental health provider confirms in writing the dying person's capacity. The individual has to make an oral request and a written request for the aid in dying medication, and that request has to be witnessed by 2 people. Health insurance benefits are unaffected by the availability of medical aid in dying, and life insurance payments can't be denied to the families of people who use the law. Anyone attempting to coerce a patient will face criminal prosecution. And perhaps most importantly, no patient, no physician, and no pharmacist is required to participate in medical aid in dying. It's entirely voluntary. New York's Medical Aid in Dying Act has broad support from a diverse and growing group of lawmakers, a wide array of civic organizations representing many of New York's diverse communities, and New York voters. More than 70 state lawmakers currently co-sponsor this bill, and the diversity of these co-sponsors is remarkable. Members from upstate, downstate, and the suburbs, white lawmakers and lawmakers of color, members who have served in the legislature for decades, and some of the most progressive newly elected members. The growing list of organizations that have endorsed the bill is similarly representative of our incredibly diverse state, and I'll just mention a small handful. Harlem United, the Hispanic Health Network, the League of Women Voters of New York State, the New York Civil Liberties Union, the New York State Academy of Family Physicians, the New York State Public Health Association, Now New York, SAGE, which is an advocacy organization for New York's LGBT elders, the statewide Senior Action Council. I also want to note that despite claims from our opponents that people with disabilities overwhelmingly oppose medical aid in dying, it is in fact a small minority of leaders in the disability rights community that have raised objections. The only polling that's ever been done on this issue regarding people with disabilities shows that they support medical aid in dying in the same measure as the general public. In addition, the ARC of New York, the state's oldest and largest disability rights organization, has adopted a policy supportive of giving terminally ill people the option of medical aid in dying. And the Resource Center for Independent Living, one of the state's largest disability rights and service organizations based in Utica, studied the issue for several years, holding forums and meetings, and currently maintains a position of neutrality on the bill. New York voters want and deserve the right to this option that our neighbors in New Jersey and Vermont now have. The most recent statewide polling on this issue, released by Marist in October of this year, shows that 59% of voters support the bill, compared with only 36% who oppose it. We also know from polling done by Lifeway, an evangelical Christian polling group, that a vast majority of Catholics, at 70%, and other Christians support this option. And results from Gallup that have measured public support on this issue for over a decade have shown a steady increase in the number of Americans who support this option. This is an issue of bodily autonomy. It is an issue of increased access to quality care. And I know that these are things that pro-choice lawmakers care about. In closing, I want to note that this law will not result in more people dying in New York. It will only result in fewer people suffering unbearably at the end of their lives. New York lawmakers have the power to stop this needless suffering in 2023, and I hope they do it. I welcome any questions you might have, and if I can't answer them here, I can follow up with you individually.
Do you have any questions for Corinne? Also question, how close do you think this bill is to passing, and what do you think has been the holdup thus far?
So I think we're going to see an unprecedented turnover in the legislature this year. We currently are working to ask candidates and inform candidates about what this bill would do, and we're actually seeing an incredible amount of support. So I have high hopes for 2023, but the real fact is we've lost over 22 advocates, people who walked the hallways, met on Zoom calls with lawmakers, and 22 of them have died during the course of this campaign. And so, I don't have control over whether this bill passes. I just really hope that lawmakers see that this is sound public policy, that the evidence supports it. And I do believe that ushering in a new group of lawmakers in 2023 increases the chance that this bill could pass. The holdups really are that it's much easier to not act than it is to act. It takes courage to do something different, and it takes very little to sit back and do nothing. So what we're asking is that lawmakers who are supportive of this become champions of this, put their name on the bill, speak publicly about it, speak to leadership. That's the only way this bill is going to move forward, is that if lawmakers are vocal in their support for the bill.
All right, thank you. If we have any other questions, now would be the moment. Otherwise, thank you so much, Corinne, for your presentation.
Thanks, Sophie.
Okay, so I just wanted to say in closing, again, thank you all so much. Thank you to our presenters, and thank you to everyone who joined us. I hope you learned something. I just want to say none of the policy positions that you have heard about today, we're saying you have to support or you must support. We just think that as candidates, as engaged and active political women, it's really important that we all know what's on the table, know what policy we are going to be encountering in the coming years, and be familiar with it. And when we talk about things like abortion, when we talk about end-of-life care, when we talk about pandemics and health services for the LGBTQ plus community, like those are things that people can shy away from, and that's what makes it even more important that we talk so openly about them. So I want to really thank everyone again so much for your time. We have more trainings coming up. Remember, Election Day is coming up, and you're going to have to vote. And we will see you at our next one. Thank you again.